what's happening to the patients that are not coming to see me? Who's proverbially about to fall into the pit that we could save? There's a human and a moral opportunity on how much better we could be saving human lives.
Today's conversation is a must-listen for anyone who cares about fixing what's broken in American healthcare. I sat down with Michael Kopko, the CEO and co-founder of Pearl Health, to talk about how we can build smarter, more humane systems, starting with how we pay for care. Mike's background is not what you might expect. He started at Bridgewater, spent years scaling Oscar Health, and now is the CEO at Pearl Health, which helps primary care providers succeed in value-based care. His perspective is sharp, systems-driven, and surprisingly optimistic. In this episode, we dig into why empowering doctors, not hospitals or payers, is the real unlock for change, how value-based care flips the incentives in healthcare, what's keeping mental health from scaling and how we might fix it, and how tech, trust, and better design could finally move the needle. If you've ever wondered why our health system works the way it does and what it will take to build something better, this one's for you. Hi, it's Mark Jacobstein, the host of Neural Compass, the Jimini podcast. I'm here today with Mike Kopko, the co-founder and CEO of Pearl Health, which is a pioneering company dedicated to transforming primary care. They're doing this through value-based care models and data-driven physician enablement. We're going to talk a lot more about what that means today. Under Mike's leadership, Pearl has expanded rapidly, now partnering with over 800 primary care providers in 29 states, and recently closed a $75 million Series B, led, I think, by A16Z, if I'm not mistaken. And we're really excited to have Mike here today to talk about all things value-based care. Prior to starting Pearl, Mike was the vice president at Oscar Health, responsible for their largest business segment. For those of you who don't know Oscar Health, it's an amazing, also a very, very fast-growing company in the insurance space. And before that, and we're going to talk about this as well, Mike was at Bridgewater Associates, the world's largest hedge fund. It's a really interesting career path, and I'm very curious to hear more about sort of the decisions that led you into healthcare. Maybe let's start with describe the mission of Pearl and what you've built so far.
Yeah, so thanks, Mark, and great to be with you and very excited about the discussion today. At a high level, we see a large shift in how we want to pay for and frankly deliver healthcare. Folks who are out in your audience, it's kind of moniker right now as value-based care, but I think longer term, we're just talking about how we pay for healthcare and what we get for it. Value is a device that helps us move from what is effectively kind of an open credit card system, fee for service, to, hey, are we getting good bang for our buck? And more innovation will come, but provider groups are not always best positioned to make those shifts. Basically, kind of reorganizing, transforming a workforce in the direction of a payment model. So Pearl was created about 5 years ago to help provider groups shift from this fee for service world to a more value-oriented one. And we're specifically focused in Medicare. A, because there's just a tremendous amount of dollars there. B, that's where the government is making the biggest policy shifts. And C, our view is that that's actually the right population where you can balance investments in changing outcomes and kind of get a return on those investments. Whereas maybe in a different population, Medicaid, ACA, commercial, today, it's a little bit of a faster twitch. You've got to kind of do something in the same year to justify it, where a Medicare, we see we've got a couple of years to invest in populations, hopefully longer. So that's what we do and very excited about it. And it's been going well. And so glad to be with you and glad to share the story.
Thank you so much. And actually, you jumped right to one of the questions I'd had, which was, you're very explicit about the fact that you work with Medicare populations. And I'm curious to dig into that a little bit more. My working assumption on that was, well, Medicare populations are the populations where we spend the most because as folks age, they have more chronic diseases, terminal diseases, expensive diseases. And so that's a great place to start your healthcare business. But it sounds like there's other structural reasons as well. And maybe for our listeners who aren't all that familiar with the way sort of primary care works in the US, how do you break it down into the sort of the segments? I mean, there's large folks, there's groups of one or two providers, sort of mom and pop primary care shops. There's huge health systems. There's integrated health systems like the Kaisers and Geisingers of the world. How do you sort of lay out the landscape in your head? And then what did that mean for you as you were thinking about, getting Pearl started?
Yeah, so at a very high level, there's approximately $4 trillion of healthcare spend. I think it tends to help by starting with dollars, and then you can kind of talk about different subsegments. But really, your largest spend population, it's kind of a tie, but Medicare, we got about 65 million people in Medicare across Medicare and Medicare Advantage. That population is growing on a secular basis more than any of the others. Next, you'd go to commercial reinsurance model or insurance models. That's employees and employers and how do people get their insurance. Medicaid has become substantial as a result of changes in kind of public health emergencies. And so we spend almost $1 trillion there, not quite. And then you've got a bunch of smaller populations, typically government pay, but ACA, TRICARE, or military spending, et cetera. So that's one way to think of it from the top down. How do people effectively get their health care and what are the spend pools there? Then to your point, you can kind of cut it the other way and kind of who delivers that care. And when you think about where the spend is on that cut, still the hospital systems, so it's typically flagged as inpatient, but still inpatient stay kind of rules the roost, even though outpatient has been growing substantially. Inpatient and outpatient tend to be owned by often the same companies when they've kind of properly vertically integrated. So that's kind of a way to think about the delivery model. And then below that are professional services or physician services, which have been pretty stable over time, but are substantive. And then probably the fastest growing category, drug spend, would come after that, and then other, which is DME and a bunch of stuff. So when you think about that kind of grid, if you will, we spend most of our time on the Medicare, column, if you will, and then what we try to influence are inpatient, outpatient, and provider spend. So you're talking about 25, 30% of all healthcare spend, and then using the tools that are 70% of that. And that's kind of where we're applying technology. And then I don't think it's radical, but in terms of for your audience, the kind of radical thesis is physicians have a lot more influence than they have to date been able to show and wield. And we are a technology and a platform that helps them deliver that influence and capture the value around that influence.
Say more about the influence. You mean the influence over the patient journey, the way people are managing their health outside of the office? What do you mean by influence?
I think influence in kind of the way we all think of it, like how are our minds and our experiences changed? And I think about that applied to healthcare. Providers and their teams, nurses, physician assistants, office admins even, have a really strong influence on patients and their experience in the healthcare journey. If you do the studies longitudinally, trust really is with the patient and the provider. Hospitals and their administrative teams have struggled. They're not considered untrustworthy, but they don't have the same trust that providers get. Same thing with drug companies, same thing with insurance companies. So really the opportunity to kind of change how a patient experiences healthcare sits in the provider orbit, and then the ability to kind of execute on needs. And so when we think about giving providers that influence, it's tapping into a very psychological, very real relationship they value, and then making that even more effective. So an example being, instead of a provider saying, you've got to go see the specialist next and good luck, can you sequence that action automatically? An appointment is booked, a ride will be picking you up, and you have a appointment with a specialist I know that understands what we're dealing with, and you don't need to go back through all the forms, repeat yourself 100 times. This is going to be just a continuous experience. That shift from the old world, we're going to see a lot more of that.
Yeah, you've touched on a couple of themes that I think are so interesting. One is this sort of continuity of care piece, which I know is actually sort of explicitly called out on your website and all the rest of it. And this notion that like, as you move from primary care to specialty care and back to primary care, and then hopefully also even just in terms of like lifestyle and behavioral change that is going to influence your overall health, there's so much breakage in the current healthcare system because in a fee-based world, not only is there no incentive, there's no system for me to move from my primary care doc who I see at One Medical to then the specialty care that I'm going to get at Stanford, et cetera. And I mean, I've actually lived this, and things fall apart. And the problem is that people's lives are busy, and so then maybe they don't follow up with a specialist, or that things just don't happen. And so the sort of seamless integration piece, which I think you said this earlier, it's not rocket science. This isn't advanced AI necessarily. This is just making sure that appointments are being kept and that they're being automatically scheduled, et cetera. Feels like it can actually move the needle far more than people realize. And it's one of the advantages of more integrated systems that they have in many other countries, and one of the challenges of a fragmented system like ours. So I'm really curious to see what the numbers look like for you in terms of I mean, I'm sure you seem like a very metric driven person based on our conversation and also everything I've read on the website. So I'm curious sort of how much of the sort of improvements you hope to see in patients and ultimately in costs are a function of this sort of continuity piece that you're discussing.
Well, so there's kind of integrated delivery systems, there's integrated economics. One of the pros and the cons, right? There's always kind of the good and the bad of our system. We are an incredibly innovative, incredibly experimental healthcare system that's always testing, trying out new things, inventing new things, deploying new effects. Because we're broadly capitalist, we're always trying to sell our services to patients. And the other very unique thing is that the buyer of services is often not the direct consumer. And so you've got this kind of really interesting model. Education gets a little bit like this in certain senses, where the things you think would make sense and would happen right away don't. So continuity of care, which we're talking about, right now, if you were having a single buyer with a single outcome, we would integrate a lot more of these workflows because that's the only way you'd be able to bill for the service. If you didn't imagine a world where the single payer says, I've got a specialty appointment and a drug to get delivered, and they didn't get to me. Well, I'm not paying for it then. But in a world where that bill is being sent to another person, and the consumption of it is not, consumer the person's paying for it, there become a couple externalities. And so continuity care, I think, will continue to improve, but it will not improve at the rate that most consumer goods that you experience. There'll be a lag. And you can kind of get into whether that's a mathematical truth or kind of a sociological one. But my thesis is it will always be informed by the best integration technologies that we have, because we can sequence food delivery, we can sequence parts deliveries, we can sequence a lot of amazing things. Healthcare will catch up over time.
I mean, we can build an iPhone, right? I mean, that's you think about like we've figured out how to do extraordinarily complex things from a manufacturing perspective with wild supply chain and logistics issues. And you're right. Sometimes it feels like you can't manage to move from like a primary care visit to the next step, which I lived this myself last year with some preventative care because my primary care physician group was not affiliated with Stanford, where I happened to get my specialty care. And it was incredibly frustrating. I have a wife who's a doctor, and I could not navigate this process.
Yeah. And I think the patient experience and navigation winds up being one of the greatest pain points. Access being a close second, this kind of from your mental health background, but being able to get a patient who has a need to the person who can solve that need, it is not a frictionless market. And that's largely because the buyer is actually not between the demand and the supply. The buyer sits outside of it for healthcare. So it's not a fundamental flaw, but when you see things that don't work the way you think they would, I'd always encourage people to think about incentives and stakeholders. And so you really have to understand that in healthcare. You also have to deeply understand payment models. Anybody who's getting involved as an entrepreneur, a services provider, and even a consumer, if you don't understand how healthcare is paid, I would say you're probably going to be quite confused on your experience.
Well, I think that goes back to what you said earlier, which is you have to understand incentives as well. Because ultimately, I'm yet to meet the human being who is not incentive driven in some way, and of course the payment models inform all of that. And so I think a healthcare system that is naive about that is not going to deliver the best care. I want to poke at something else you said earlier, which I thought was really important, which is patients trust their providers far more than they trust sort of the rest of the healthcare ecosystem. And I think probably very good reasons for that. There's almost nobody who goes into medicine, whether you become a nurse, a doctor, a therapist, et cetera, who isn't a caring person. People do this because they're empathic, because they want to help. And there is an enormous amount of trust. I've long thought that we don't leverage that enough, that so much of staying healthy is about work that happens. Not just what you show up at your doc's, maybe you've got strep, they're going to give you amoxicillin, terrific. We know how to treat that. But most of what happens with our health, I feel like, is a function of things that take place outside of the doctor's office. And that the trust component that a therapist has is one that can help to guide behavior. Now, I have a very particular lens on this because I work in behavioral and mental health. But my sense is that folks like yourself who get to sit across the entire ecosystem and see not only sort of where the dollars are spent, but like where the illness actually is, probably concur with this, that the role of the provider, and probably in particular the primary care provider, can be more expansive and can be used to sort of encourage the right behaviors maybe that's just go see the specialist, but maybe it's also changed something within your lifestyle in ways that are really profound and important.
Yeah, I mean, I think when we think about costs and what explain costs in healthcare, the kind of suite of providers that serve a patient, primary care, cardiology, neurology, orthopedics, those folks really understand the root cause of issues. And when you think about solving those issues, what I would kind of share with your audience is we know almost everything about patients at this point as a kind of collective brain.
Yep.
We can predict almost all health outcomes at this point. There are very few accidents in healthcare. There are some, to be clear, but the deployment of resources is broadly deployed on things that are highly predictable. And so what I think is becoming increasingly clear is if you can predict it, you can prevent it. And provider groups, providers as themselves, leveraged by nurses, physician assistants, good technology, you can do a lot of that, especially in a digitally enabled world, outside of a hospital structure, a concrete block, a physical construct even. And I think what you'll see in our healthcare delivery model is it's going to move much more to that. Being able to access you at any point in time where you are, get you what you need, regardless of your physical location. And that will lead to better outcomes for us all. But you've got to know who the players that really accelerate that outcome. And I think it's going to start with providers and their teams.
We certainly concur at Jimini. I mean, I think a confluence of a variety of things, including like the big push into telemedicine that, of course, was accelerated enormously by the pandemic, the dawn of mobile, which really started about 15 years ago, but the ability to have mobile devices with you at all times and everybody being connected via the internet. But I think also provider comfort in using technology to help sort of extend their reach into various places is also a really important part of this. And I mean, it squares with our thesis at Jimini, which is that the ability to deliver care to people sort of at all times when they need it, where they are, is a really important sort of use of technology, some combination of mobile and AI to enable that. But I think that extends well beyond behavioral and mental health. I think this is true whether you're managing your diabetes or you're managing your heart disease, your COPD, or your major depressive disorder. All of these things can be improved with the use of technology that sort of meets you where you are. That's certainly core to our thesis.
Yeah, and I think that's the big disruption because what the healthcare system, think of it as like kind of more of a pre-tech or a pre-hyper-tech world. It was allowed to get away with not serving the customer where they are because the customer wasn't paying. When you look at kind of the customer was direct paying about 10% of healthcare expenses. So yes, you want to keep them happy, but who's paying the 90% of the bill? That's the employer, the insurance company, the government. In a world where technology now can start breaking down those barriers and those moments become critical to consumption and to outcomes, you're going to see massive shifts. And I'm very long in technology in terms of the application to healthcare. So there's always kind of a refuge for Luddites and people who are a little bit opposed to it, just because it moves a little slower and it needs to be a little more empathetic to all of the different people. But if you think about where we are as a society going in terms of our technology adoption broadly, and the children, the high school children, the college, the working, so then Medicare, and that progression over time, the construct that I have to show up to a physical place, wait for an hour, get recertified for eligibility to then get this key service for a bill that 90% of us are all paying it. We're going to say that's ridiculous. Cut down all those barriers, get them what they need, deliver the drug at their home. Why would we want to all pay for a collective emergency room and inpatient stay when we can have an Uber or a capsule or a whomever just drop off the drug they can't pick up? And you mentioned your kind of challenge with interacting with the healthcare system. I think over time, when those things lead to bad outcomes on an expense level, we will become increasingly impatient and unaccepting of those outcomes as well. But it may take AI, LLMs and kind of natural language systems that'll say, let's just kill the phone tree. Why do we need that?
It's interesting you mentioned the LLM because in some ways, the AI hype cycle has been very, very intense for the last couple of years, largely because of the rise of LLMs. AI in general has been on the rise for 10, 15 years, and lots of very important applications in the medical field that have nothing to do with LLMs. But the LLMs provide an interface that sort of the last mile delivery ultimately is like human beings need to understand the thing that they're being instructed to do. And LLMs and their ability to have essentially a conversation with the patient, or for that matter, the provider, makes everything so much easier that I do think it's a very, very important disruption on top of all the other things that have been happening vis-a-vis software. I do think the advent of mobile is probably almost as important as well, because now I can actually deliver the care. I can deliver the conversation or the appointment or what I need to sort of in a local manner. I want to shift the conversation just a little bit, though. One of the most interesting things about your background is, as I think of you as like the value-based care warrior now, is that you started at a hedge fund, which is not like the normal path. I think a typical background for somebody like yourself who's a CEO of Pearl might be like, you started life as an MD, you saw all the frustrations, maybe you primary care, you lived the frustrations, you saw all the challenges. I mean, it's interesting. I have a friend, Kina Fong, who started Elation EMR, which you may know. Which is
I know Kina. She's great.
She's great, right? Kina knows everything, and Elation's this wonderful business building EMRs in the primary health care system. Well, that's not a coincidence. Kina's father's a primary care physician, and she sort of saw the challenges of like, he just wants to give care, but he needs the software and systems to be able to do it. And he doesn't want to have to think about it. So it needs to be really, really easy because he's a doctor. He's not an IT professional, et cetera. You don't have that background. You started at Bridgewater. And I mean, there's a lot to unpack here in terms of, for those who don't know, Bridgewater is pretty famous because the founder, Ray Dalio, has written a number of books, but it has a whole sort of philosophy about being very data-driven and very meritocratic and a lot of logic that I think I was starting to think about this last night as sort of like, I can see how this pulls through into this business, but I'm curious to hear sort of your journey from that to Oscar to Pearl. Like, how did this happen?
Well, I would say my kind of career is one of kind of entrepreneurship and serendipity. I think as an entrepreneur, I've always figured, how can you deliver the most impact with your capabilities, and where is kind of the emerging opportunity horizons, and can you kind of throw your energy into those? And then as you get, more scaled and more experienced, you can typically pick up teams and you can kind of build on your energy and use that to power others. I started out with not really a healthcare background at all. Frankly, I was very interested in genetics as a young kid. I mean, precociously interested, I was subscribing to Genetics News Weekly when there was a newspaper in middle school. They had like a free student version, which was so cool. They were charging academics a fortune for it. And I was just interested in it because I think I believed at that time, even we were going to be coding human beings. Took a lot longer, frankly, than I would have thought, but nonetheless, we're kind of getting there.
We're working on it.
Yeah, we're working on it, right? And then, in terms of serendipity, I was very lucky to just get into good educational systems, and your peers and your parents kind of push and pull you up, and you just take advantage of that. And I think the moment I joined Bridgewater was actually the moment where I had good mentors saying, you're very entrepreneurial, but go learn from the best. Figure out how systems work. You don't need to invent a payroll system. You don't need to invent a performance system. You don't need to invent, all of these types of things you as an entrepreneur will scratch it out on. And that was an amazing gift. I loved working with Ray. I think he's, it's like Bono meets hedge funds. Like he was just working with a rock star.
Yeah.
He was very big on radical transparency, which was something I didn't have the words for it, but I always believed when I was an entrepreneur working with my classmates, you just got to be honest with each other. I could always kind of smell someone who wasn't telling you the truth, and never wanted to be that person to someone who was kind of giving their life to something you were working on. And, despite maybe some flaws in that, like that's kind of a governing principle. And then kind of met Oscar when it was getting started because I had known Josh from college, and it was completely, a shift. I had no intention of going to healthcare, but there was this big opportunity with the ACA coming out. So we were very excited by that. And, little did we know that 7 years later, we take it public and kind of whole tour de force of how the healthcare system works. And I would say, maybe at the end, it's like I'm a systems person. And what I'm still motivated by is I think the healthcare system is still, frankly, pretty dumb. And I say that with respect because I know a lot of human lives have been put into building it. But when you just think about, I watch people walking around even now, what they need, and will we get it to them? We are, 10x away from how efficient we could be, 100x, 1000x. We know the problems, we can solve them, and we need to build a system to do that. And I think I'm not the only one, but I'm uniquely positioned to help agitate and push and deliver that type of change. And it's completely doable. This is not mission impossible. It's just, you have to be willing to take some pain and deal with nonsense and keep moving forward every day. But we can build the best system the world's ever thought of for delivering healthcare today. Nothing is in our way except our willpower.
So I love so much of what you've said here, including the idea that you're a systems thinker, because I agree it's mostly a systems problem, right? That like all these individual components, we have phenomenal doctors, phenomenal nurses, phenomenal hospitals. We have amazing research. We have terrific drugs. We spend an enormous amount of money. There's no lack of sort of financial resources, right? We spend 2x per patient what any other developed nation does for worse outcomes. It's a systemic thing. And I would argue that sort of like, it's been neither natural selection nor intelligent design. It's sort of these bizarro constraints that have created this monster. And hopefully people like yourselves and firms like yours are going to help fix this so that we have everything from continuity of care, data moves more freely, decision support that actually makes sense. And the clinicians and providers are able to focus on the patient rather than thinking about all of the cruft that is sort of surrounds them, whether that's, and we're seeing this, simple examples are like AI scribes, right? Everybody loves their AI scribe. It's like, I think it's the first feature I've heard of where every single provider ever is like, oh, this is thank God, right? But I think of that as like the tiniest like example of the type of things that can get pulled through the entire ecosystem through some combination of technology, but I think more importantly, systems. It's sort of about getting the stuff deployed because the tech is already there. Such an interesting path. And I mean, the other thing that jumped out at me is, I think about hedge funds in general and maybe Bridgewater specifically, it's about measuring, it's about data, right? And presumably for you, because you sit in the middle of the ecosystem and you see many, many providers and even more patients, and you understand what people ultimately cost in the system and what their health outcomes look like and all the rest of it, you're able to like put your finger on the pain points. One of the things I thought was really interesting is you have a dashboard, and this is something you feature right on the top of the website. So I assume it's pretty important for the provider experience that shows the providers who to be concerned about, right? And who haven't we had enough contact with, or who do we need to have an intervention with? Because there are patients with whom they're healthy-ish and life's easy and good. And then there's the ones that are going to, if they aren't getting the care they need or not taking the drugs they need, they're going to cost the system all the money. And so anyways, I'm assuming this is all data-driven, but I'd love to hear sort of more about how you think about data and data visualization and the rest of this in the physician experience.
Yeah, absolutely. I mean, one of the things that I think is a big shocker to folks who've been outside of healthcare and kind of come to, we are incredibly backwards looking when we think about addressing healthcare needs. The fee-for-service system is a cause of this. But basically, if you interview physicians, their model has historically been, I wait for someone to come and see me. And it is often incredibly self-guided and self-motivated. There is very little in our system today, even today, on a relative basis. We know something's about to happen, so we got to talk about it. This is coming up. Our models suggest this is, going to be an issue. And so value-based care allows a big unlock. It's not going to be the only and not going to be the last, but it forces you to go from a rear view looking world to a windshield looking world. What's happening to the patients that are not coming to see me? Where are resources going to go that we could be avoiding because they're completely wasteful and unnecessary? Who's proverbially about to fall into the pit that we could save? And I think, there's a human and a moral opportunity on how much better we could be saving human lives. Like, one of the metrics I've always thought of for Pearl is how many human life years can you save or extend? But, more importantly, because of data models now, and if you think about a much more interoperable, and let's call it a HIPAA modernized world, we kind of know everything that's about to happen. And if you wanted to subscribe to the Save My Life system, where I never want a bad thing to happen to me or a loved one, our models now are better. It's like having all the power of all the physicians in the world watching out for you. And we're there now. I'm going to make some connections to be sure, but the science is not the tricky part. It's the kind of anthropological, how do humans come together to do this? And I'm very excited by the potential of that world. And I think AI will be a massive device in allowing that. Data is a critical one. Our data kind of philosophy is more data is always better, sure. But really it's the right information delivered at the right point in time that matters. The internet went through this version of how do you kind of deliver packets of data efficiently. Healthcare is going to be this version of how do you deliver intelligence efficiently? You can't just show up to a doctor and say, we're going to dump 10 terabytes of data on your EHR. That doesn't help anybody.
Right.
In fact, it makes them worse off. What you have to think about is your surface area where you're interacting with patients. We're going to increase the intelligence of that surface area through these technologies and tools. And the good thing and the critical thing that has to remain true for this to keep getting better is the payments are attached to that. Because, you can say all you want what someone should do. Until you pay them to do it, you might as well be writing an article because you're not really changing the system without changing the incentives.
Well, this is one of the things that's so critical about value-based care, right? Is it allows you to move to a world like the creative power of a capitalist economy is pointed in the right direction in terms of like we're actually maximizing human health and happiness in a value-based system. It is not in a fee-for-service world. And so you end up, the misalignment causes ultimately like lack of care or worse outcomes than you could have. And so we talked about incentives to start all this. You move towards value-based care. You basically unleash the power and creativity, whether it's from the creation of new drugs or just the building of better systems on we're going to ultimately drive better health outcomes because those are also less expensive, right? If I'm healthier, I don't show up in the ER, everybody wins, including the patient. So speaking of sort of the ability of knock-on effects to be very important, one of the things we think a lot about at Jimini is that mental and behavioral health is important in and of itself. People who are struggling with depression or anxiety or serious mental illness want relief from that suffering for sure. Also, those challenges have knock-on effects. I think of anxiety and depression as like the ultimate comorbidities, right? If you're depressed, your diabetes is going to enlarge, is going to be more expensive and more difficult to treat and get worse. Your COPD is going to get worse. Whatever it is that you're struggling with from a physical health perspective is going to be that much harder to treat and that much more of a challenge if you're also struggling with mental and behavioral health issues. Despite that, historically, payers have they don't love paying for mental and behavioral health stuff. And one of my hopes has always been that in a value-based world where you sort of get to see the long-term HECON stuff, if I do a good job treating anxiety, good job treating depression, good job treating schizophrenia, I see that not only is this person happier and healthier, but they're less expensive in terms of the overall costs. Is this something that is a priority for Pearl? How do you think about mental behavioral health in the context of all the other care that you need to provide?
So behavioral mental health is clearly a very important, under-accessed, underutilized resource for our country and our world more broadly. That's kind of my governing compass. That said, it also, I think, has one of the highest burdens as it relates to getting into the value-based care and in certain ways the fee-for-service world. And one of the challenges, and you know the category better than I do, but at least from coming from the insurance side and now the senior and geriatric side, is the cost of the solution and its kind of demonstrable impact have had a mismatch such that it has become more of a private pay good, all things equal, relative to a public pay good. And what I mean by that is, yes, we all support it, but then when you think about allocating public dollars, tax dollars, your dollars to it, you'll say, yeah, let's make sure it's covered, but let's not go hog wild here.
Yeah.
And so there's kind of a limitation on dollars today in the behavioral health category. Now, that doesn't mean that it doesn't create value. That doesn't mean that it's unimportant. But I just wanted in terms of set the kind of monetary stage, if you will, for mental health. Now, I think there's a huge opportunity in two ways. One, if you can figure out ways to bring the cost of providing it down, which my understanding of what you're all building can do that radically, right? I mean, 1/100th the cost, 1/110th the cost, et cetera, a tenth the cost. That's a massive unlock. And the second unlock is when you can tie good outcomes to reductions in direct costs and direct conditions. And I think that's more of a data science problem in truth than it is an impossibility. But it's tough to go from the parochial, my solution makes you better, to, hey, at a population health level, populations treated with this mental health capability are able to lower costs and lower condition load, lower risk scores, et cetera. When we get to that level of truth, then I think you're going to see an investment. And if you get the cost of delivery down, you could see a real opening of the aperture.
Yeah, I agree with that perspective. I guess the way I think about this is currently we have an access issue. We also have an efficacy issue. So there's been both a ceiling in terms of the efficacy of many treatments in mental health for quite some time, which we think new ways of providing care, for example, continuity of care, not just seeing your therapist 1 hour a week, but sort of when having access via AI, potentially when you need it, et cetera, we can improve efficacy. But also there's been an inconsistency in the quality of care in the system that maybe doesn't exist throughout the entire health ecosystem. It's one of the things that I know drives payers nuts is that they don't necessarily know whether a behavioral intervention with a given therapist, the type of therapy that somebody is receiving, et cetera, is actually all that effective. And in a way that it's true in some other parts of medicine, but if you give somebody who's got strep amoxicillin, they're going to get better, right? And so there's been this challenge of are the interventions as effective as they could be? I think they can be more effective. Are we measuring how effective they are? We don't do nearly enough of that in mental and behavioral health, even when people are getting better because of their combination of drugs and therapy or whatever. We don't measure it in a way that gives the payers a lot of comfort. And I think, again, technology can help us change that. And then to your point, the access issue is a function of we don't have enough therapists, we don't have enough psychiatrists, enough psychologists, enough LCSWs, et cetera. But also, to your point, it's reasonably expensive to pay for human time. Can we maintain what's most important about that human time, the human connection that people find really, really important and valuable? And we talked about provider trust earlier is really critical. And a human being who's sort of overseeing your overall care, because humans are still best at that. But then augment that with technology in a way that really, really brings your costs down, right? And I think that's the vision. Obviously, there's a lot of work between here and there. But if we can do that, then you can pull that all through to the health economic study that you want to run that shows that, and oh, by the way, not only did this make this person happier and we alleviated, say, their major depressive disorder, it also in the aggregate makes the rest of their healthcare journey an awful lot less expensive as well. And as such, we should be putting a lot of resources towards this. And that's certainly part of the vision for Jimini. And I think a lot of the companies in our space, but there's a lot of work between here and there.
Yeah, there's going to be a lot of progression. I'm excited about it. I'm glad to be getting to know you all and be able to spend time with you. And I think we're kind of just getting started in that journey.
Fantastic. Well, Mike, I really appreciate the time today. I know you're busy and on the road and trying to get some deals closed as well. This has been a fascinating conversation. I'll close with this one last question. Do you have anything? This could be a blog, a podcast, a book that you've been consuming lately that you think is really interesting for people who are interested in the issues that we talked about today? A fantastic book, a great blog post, a really interesting podcast, a movie, something that you think sort of ties into some of the themes we've been discussing today?
Well, I read kind of a lot of stuff. I would say Health Tech Nerds is kind of the diet where you're kind of covering the healthcare landscape. I think a lot of folks are on that. Yeah. I have not found kind of my frequent AI. So I'm just kind of reading through them that's being produced. Their abundance is on my list now to read next. I'm kind of reading Howard Zinn's History of the United States. I really think it's good to bring a wide range of reading to helping facilitate big changes, because you've got to appreciate history. Time didn't, start because you showed up. And then you've got to understand technology, because if you don't have a vision, things won't change. So I'm trying to balance those two things and keep reading stuff. But I
love that. By the way, I don't know that I've ever heard somebody drop Howard Zinn. And I just started Abundance. I think it's going to be very interesting. I think I'm generally very much aligned personally with Ezra Klein on this one. Anyways, that's a terrific list, and hopefully folks will check some of that out.
Appreciate it,
Mike. I really appreciate the conversation today, and look forward to getting to know you.
Thanks, Mark. Appreciate you all, and rooting for Jiminy, and talk soon.
Cheers. Thanks.
All right, go get them.
Thanks for listening to Neural Compass, the Jiminy podcast. If today's conversation sparked something for you, follow us at Instagram, YouTube, or LinkedIn, or explore more at JiminiHealth.com. At Jiminy, we're building the future of mental health care with effective, safe, AI-enabled continuous care. See you next time.